coming lecture دكتور محمد حسنين. أرهقنا النهارده الحقيقة دكتور محمد محاضرات طول اليوم بس أكيد آخر واحدة هتكون أحسن واحدة وأستمتع بإذن الله. Clinical approach for hypertension in diabetics.
ممكن تعمل لي سكرين؟ اتفضل. سبليت سكرين. تمام. اوكي السلام عليكم. على الله بس ما تكونش زهقتوا مني. طيب The discussion today or now is about hypertension management from a clinical point of view. And what I would like to do is to move the slides, but they're not moving. Okay. So I don't think we need to talk too much about the prevalence of diabetes. You all know it by heart. You know it also related to age. But the point of the age relation is obviously as we get older, our blood pressure tends to get higher. So it's really quite important that we try to understand these points. We looked into the prevalence of hypertension in the Emirates of Dubai in a recent study, and we found that nearly a third of the population have a blood pressure above 140/90, and another third have blood pressure between 120 to 80 and 120 to 140/80 to 90. And this is not very much different between locals and expats. In fact, in expatriates, it's higher. Perhaps it's related to higher level of stress. Now, when you look into the prevalence of hypertension in people with diabetes, you will find that this is very much higher. It's almost double the level of hypertension in people without diabetes. I presented this information earlier this morning, very, very recent data. We haven't really even considered to put it into any manuscript yet. We just looked into patients with vascular problems, cardiac, renal, and foot problems. And we looked into how many of them are achieving the target blood pressure. And unfortunately, a lot of them are not achieving the target blood pressure. So what does the ADA say to us? Blood pressure, of course, needs to be measured at every single consultation. And of course, we will not diagnose hypertension with one reading. We will have, obviously, to look into a number of readings. But the following slide has been seen or presented today numerously by numerous speakers. Blood pressure management is one of the pillars of the management of cardiovascular disease in any person, whether with diabetes or without. So the big issue is the treatment goal. We always like to achieve the goal. So what is exactly the treatment goal for a person with diabetes? You will find here some differences between one organization and another. So while the ADA is saying that in people with high risk, the vascular persons, their aim is to be below 130/80, and for others, it is below 140/90, you will find that other organizations are saying something slightly different. The European Society for Cardiology, their target is to be below 130 in the vast majority of people, perhaps in people of older generation of above the 65 years age, they try to make it between 130 to 139. So the Europeans tend to recommend a slightly lower blood pressure in comparison with the Americans. What should we use or what should we treat? Which agent? Well, before we think of agents, of course, we need to think of lifestyle. And this is not just a word that we say. We really seriously need to take the lifestyle measures that leads to hypertension or can improve blood pressure management very seriously. So the recommendation for people with diabetes is a RASP blockade and the possibility of calcium channel blocker as well, or thiazide diuretic. and the recommendation is to combine from the European. The American recommendations is we only go for dual therapy if the target is too high. So if the current level is above 160/100, then start with dual agent. If the actual blood pressure is under 160/100, but above 140/90, then you start with one agent. And they differentiate between whether we would use an ACE inhibitor or an angiotensin II antagonist based on the presence of renal or vascular problems or not. And of course, when you intensify, you would intensify based on these parameters. You would think of combining one class followed by the other in the sequence of A, then C, then D, and then eventually you start thinking of considering the spironolactone, the beta blockers, and the looped diuretics. As I mentioned earlier this morning, we have developed the cardiometabolic guidelines of the UAE, which is a joint development between diabetologists and cardiologists. So to get diabetologists and cardiologists to agree on something is really not easy, but alhamdulillah, we've managed to do it. And as you can see here, we have different levels of risk categories. We have the very high, the moderate, and the low. Obviously, in our societies, we have people who are diagnosed with diabetes at very young age. We diagnose people in their teenage, 19 years old, 20 years old, 17 years old with type 2 diabetes because of the lifestyle and because of the prevalence of maybe the wrong genetics. So I wouldn't consider everyone with diabetes as high because we have many young people with diabetes. Obviously, the multiplicity of risk factors means that a huge proportion of our patients are with multiple risk factors or with undiagnosed cardiac problems. The option that we had for our guidelines, knowing the high risk in the population, in the Arab population of obesity, sedentary lifestyle, high prevalence of smoking, meant that we have opted for a lower blood pressure for everyone with diabetes, aiming for a lower blood pressure of below 130/80, and we have opted for the high risk for an ACE inhibitor or an angiotensin II antagonist for the very high and the high. For the moderate and the low, we opted to use any anti-hypertensive agent. So, of course, we also need to understand when do we call someone with resistant hypertension. And my very good friend Mick Mwenda have covered or will be covering in the conference this topic, so I wouldn't like to dwell too much about it because it's been covered. But I would like to go back to the lifestyle management because I think this is a neglected part. We as clinicians, we tend to focus far too much on the debate of which drug, ACE or ARB, calcium antagonist or a thiazide diuretic or loop diuretic or non-thiazide diuretic. And the bottom line is we forget about the lifestyle management. Lifestyle management is really quite important, and the ADA have highlighted to us that the dietary approaches to stop hypertension, what they call DASH diet, is really very important aspect. You can argue as well that Mediterranean diet is very important. But looking into what are the details of this diet, so think not just about DASH or Mediterranean or whatever. What should you advise your patient? You should advise your patient to cut down on sodium and increase on potassium intake. I'm not obviously talking about high potassium intake in someone with seriously impaired renal function. I'm talking about someone with hypertension and with a reasonable renal function. Potassium helps to normalize the blood pressure, and sodium increases the blood pressure. So thinking of the right content of the food would be very important. Of course, increasing physical activity is crucial, and for those who drink alcohol, knowing that alcohol can increase the blood pressure. So I'm not planning to show you again the British International and Hypertension Society. I just want to take from them a couple of the important words. Lifestyle, as well as home blood pressure monitoring, as well as education and advice. We talk to our people with diabetes on a lot of points, but we hardly talk to people with hypertension about what should they do. And again, if you can see, what does the European Society for Hypertension, along with the European Society for Cardiology, say about this motivational session, educational session for hypertension, group session, self-monitoring of the blood pressure, self-management with simple patient guidance. Now, many of you work in private sector and they can't afford to say to their patient, come next week or come in 2 weeks or something like this. I work in a governmental sector, and unless it's an emergency, I cannot see the person within 3 months. So it really needs, so how would the person titrate their therapy? Would they wait for 3 months? The Germans and the European give the patient algorithms and teach them, check your home blood pressure. In 2 weeks, if your blood pressure is still high, go on this dose, and so on. Now, I'm very passionate about nutrition in diabetes in general. I was lucky enough to do a degree, a Master of Philosophy in Human Nutrition. This is my photo with my family, my parents, rahmatullah alayhim, and my wife on the day of graduation 2005 for an extra degree that I wanted to do in nutrition. And I think that combining the nutrition along with education for hypertension is very important. This is the study that a randomized controlled trial, which we did in UK, along with my good friend Mick Kumwende, and one of the professors, actually 2 of the professors from Alexandria University who took part with our work. They came to our center in UK, each one for them for 1 year, and they were part of this important study. The Structured Hypertension Education Program for Diabetes, the study that we called SHED trial. The guru for the thought of the study is Professor Ingrid Mulhauser from Germany, from Düsseldorf. I met her once in Egypt and she was talking to me about the hypertension program. And when I asked her about details of it, I understood that they did it, but they did not do a randomized controlled trial. So I asked her for collaboration and we took the program and we made it a British program by modification from German to British. And we applied it in our center. We randomized 132 persons into 2 groups, the intervention group and the controlled group. So before we talk about the intervention group, the control group is people who would be seen in a clinic in UK by a consultant, be diagnosed with hypertension, advised on the treatment of hypertension, and then will be seen every 3 months. The intervention group were the group who had the structured hypertension education as well as home blood pressure monitoring. The education was 4 different sessions of 90 minutes each. And they were provided by people who understand education as well as a physician. And we talked to them about very important messages that include the salt intake, salt restriction, weight, alcohol, physical activity. We talked to them what is systolic and what's blood and diastolic. When you say to a person, a normal person, your blood pressure is 140/90, do they understand what is 140 and what is 90? What is the big number and what's the lower number? So they needed to understand a bit more. They needed to understand why do people get hypertension, so that they start thinking and understanding the process and try to address it. They also understood what is the impact of high blood pressure on different organs of the body. And indeed, how do different classes of drugs work and what is the expected side effects profile so that they can anticipate the side effects, tolerate it if it's tolerable. We talk to them about what is sodium. How can they read the sodium content in food and find out that this type of cheese is rich in sodium, this type of food is rich in sodium, this type of food is low in sodium and better to take it. We gave them blood pressure monitors, or we advised them to buy a we gave them a blood pressure monitor, and we explained to them and we taught them how to measure the blood pressure at home. Now, we advise people with diabetes to go and buy blood glucose monitors. The strips are expensive. The glucometer or the glucose monitor lasts for a number of years. I calculated the cost of buying a blood pressure monitor versus the cost of buying a blood glucose monitor and glucose strips for 3 years. And you see the difference. The blood pressure monitor will be 160 dirham. The glucometer and the strips for 3 years will be 5,060 dirham. I'm sure the cost in Egypt is different, but you probably will find it's more or less the same proportion. So the question is, did education work? Did home blood pressure work? Did knowledge work? And here is the data that we have published into the journal. So after visit 1 in the education group, the blood pressure dropped from 159 to 141. And by visit 2, 24 weeks later, nearly 6 months later, it dropped 139. There was a huge, significant figures between one and the other. In the routine group, it also improved, but not at the same level. But the important point is, when you look into the diastolic as well, very much improvement, much more improvement in the education group versus the routine group. So percentage of people achieving targets. So blue is the education and orange is the routine. So look here into the percentage achieving the target blood pressure after 12 weeks and after 24 weeks. 60% in the education group achieved the target, while only 20% in the control group achieved the target. And the beauty is, we achieved the target with lower number of tablets. Here is the increment in number of tablets in the education group versus the increment in number of tablets in the routine group. So in conclusion, ladies and gentlemen, hypertension is highly prevalent in our population, and this is more prevalent in people with diabetes. The coexistence of hypertension and diabetes are indeed associated with very high rates of macro and microvascular complications. We've heard earlier this morning about the neuropathy being related also to hypertension. The health benefits from hypertension treatment are higher than the health benefits of treatment of hyperglycemia. We have multiple guidelines with no major differences. We should not argue the target is 140 or 130. Let's get one, adopt one, apply it, and if you're able to achieve even tighter target, no problem. Hypertension in people with diabetes remains largely undiagnosed and largely poorly controlled. We need to think holistically, not just prescribe a tablet. We need to advise about all the cardiovascular risks, the smoking cessation, the physical activity, the lipids management, the right salt, the cut down on the sodium and the increase of the potassium, and of course, home blood pressure monitoring. All this means we need education, education, education. Thank you very much.